So luckily today you actually don't have to listen to me very much, because being the chair means you get to listen to the really smart people and I just have to direct the questions towards them. But I do have the privilege of introducing everybody. As John mentioned earlier, you have the bios, so I'm not going to go through the whole bio, but I do want you to know who's who up at the front here. So immediately on my left is Troy Stooke, who's the co-chair for Healthcare 101, Imagine Citizens Collaborating for Health. And we actually have got the great fortune of working together on the MAID Regulatory Review Committee as well. She's our public member and has just started, but is tremendous value to that organization as well. Next to her is Dr. Tina Korownyk, and she's from the College of Family Physicians and co-director Evidence and Continuing Professional Development with the Alberta College. So welcome. And next to her is Sheri Fielding, Clinical Director and Nurse Practitioner, Southside Primary Care Network. So it's great to have a nurse practitioner here with us as well. It's important that we have all of our healthcare providers and team members working together as we move forward. And next to her, oh, we have Kathleen. Sorry, I couldn't see who was next there. So Kathleen Ness is next, and she is Alberta's health advocate, or health advocate, patient advocate, and new into the job, but incredible experience working with government, and certainly understands policy and understands working with the other healthcare providers. So it's great having her on the panel as well. And next to her is Dr. Shawn Dowling with the Physician Learning Program at the University of Calgary. Thank you as well. Trying to teach physicians is never easy, and you've got some challenging work ahead of you there as well. And of course, the far left there is Dr. Don Dick, Quality, Safety, and Outcomes Executive with AHS. So what we're going to do to start with is we're going to start, and probably just so I don't pick on Troy, I'm going to start on the other side with Don, and everybody's going to give us about a 2 to 3 minute quick summary of some of their thoughts on the topics that we have today. We're going to try and keep that part of the presentation down to about 30-35 minutes, because we want to spend our time interacting and getting lots of questions back and forth from the audience here. So Don, over to you.
Well, thank you very much for this opportunity to be on this panel. And Catherine, that was very inspiring. The area that resonates with me is the variation in outcomes. Because right now, my current role is the Medical Director of Improving Health Outcomes, the IHE team. And this is something new in Alberta. We didn't have a team focused on this before, but really trying to look at outcomes, appropriateness, and variation. And my first learning in the past year has been it's complex, and it's not quite as easy as I thought it would be, because I'm an orthopedic surgeon. I'm one of those guys who puts those bad knees in that sometimes don't work. But as a surgeon, we're used to making decisions quickly, and we're used to yes, no, move on. And the area that I'm working in now is not quite that black and white, it's gray. And looking at variation across the province, and we do have variation in this province, we have variation in outcomes, we have variation in costs, and we have the frequency of procedures vary. If you look at, like you said, one area of the country has significant variation in the numbers of knees and hip replacements. We have that in Alberta as well. But we also, and more important from where I come from, is we have variation in outcomes. Our outcomes aren't universally the same, and there's variation in costs, significant variations in costs. And so what you said really resonates with me, but it's not black and white. It is dependent on data. We really do need good information, and we have the ability to actually take this information and move providers and healthcare leaders in one direction or another, and that's what I'm currently trying to do. I don't know if that was what you wanted for introductory comments, but
that's perfect, Don. Thanks.
Okay.
We'll just keep moving down. Great.
So thank you very much. Like Dr. Dick, live in an interesting world where I get to interface with the realities of realistic medicine every day as an emergency physician, talking to patients about what tests they need or don't need, or what tests they think they need and may not need, and what tests they expect and I can't unfortunately deliver at times. And as a clinician, it's very challenging. As an academic, trying to convince physicians that realistic medicine or choosing wisely or value-added care is something that is a responsibility and not an extra ask of physicians is very challenging because, as clinicians, we are faced with expectations from patients. We're faced with, access to resources, medical legal risks, or medical legal concerns, whether they're perceived or real, perceived standards of care. All these things influence whether we do or don't do tests on a daily basis. And unfortunately, sometimes the culture in medicine doesn't support us not doing things, and that, any clinician can talk about how they've seen someone get thrown on the bus by another colleague because they didn't have a test done that someone else perceived, and then the family's not happy with that outcome. And if we're going to create a culture where we include patients' expectations and appropriateness of tests and value-added tests, and we also have to create a culture that supports that decision-making. As a clinician, that's difficult for me to put in practice. It's much easier for me to talk about as an academic when I talk to physicians about this. A lot of what we do is the work that Braden was talking about in terms of audit and feedback and getting individual clinicians their data. And not only getting their data and using that data to actually change practice and not dismiss it, because far too often that's what happens when people get these reports about the variation in care. They dismiss the data, or they think that this is just a checkbox that some group needed or some organization needed to send out to them, and they don't see it as an opportunity for self-reflection and quality improvement. So a lot of what we do is dissect that variation in practice and try to get clinicians to identify changes and opportunities to change to go forward. So that's where I'm excited about what you've been talking about and hope to have more discussion about this afternoon.
Thank you very much. Kathleen.
Thanks very much. I was reflecting as I was listening to the presentation around strengthening relationships. So for the last 3 years, I've had the wonderful position of being Assistant Deputy Minister for Health Service Delivery. And in that, I thought about what we did in rolling out the Dowling Mental Health, which started with very small group of stakeholders, then ended up with a very large group of 250 people and voices around the province, because in fact what we were trying to do is an impossible task of trying to deal with mental health across the entire province with very short and limited resources. When I was asked to take this position and appointed in July of this year, so very new to the role, what I realized is that many of the things that we've been working on across the province for the last 3 years, or that I have been working on, very, very, very much align with realistic medicine, but they're siloed and they're in pieces, and they're really good pieces of work, but they haven't necessarily been branded and coming together. The Advocate's Office responds on a day-to-day basis and gets to hear the themes of where the gaps are. So in the short time that I've been there, I've been very impressed with observing the staff and how they interact with the client, because at this point, they really aren't there to respond. They're there to listen, to help to navigate, to figure out where the problems are, to help get some resolution, but most importantly, also to educate. So we have a wonderful, wonderful system in Alberta, but not everybody knows what it is and what it looks like. So part of the three things, I guess, that I would say is that we have often designed hoping the patient would fit into the system instead of having the system designed so the patient can fit into it. We know that we have performance metrics that are not always necessarily asking the patient or necessarily helping to have advanced what they want to have. I don't know if I took a poll in this room, how many of you know that we actually have a health charter? In Alberta, we have a health charter that was put in place at the time that the Health Advocate's Office was put in place. And it says, when I interact with the health system, I will. And there are 11 points that are very, very much that resonate with the realistic medicine. I don't think in Alberta we've actually taken that to the implementation phase of making sure everyone knows and that they are able to exercise their rights and also by able to work with a whole lot of providers to make it work well. So it's a culture and a dialogue change. Thank you.
Thanks very much. I think from a very practical primary care perspective, one of the things that we know we need to do, and we've been talking about it for a long time around shared decision-making with patients and personalized approach, is really having the time at a practice level to see what that looks like. Work with patients outside of those one-on-one or face-to-face appointments to sit down and talk about, let's use goal setting as an example. So our clinic recently participated in a pilot with toward optimized practice and AHS called Patients Collaborating with Teams, or PACT. And one of the main constructs of this project is to set up some sort of goal-setting care plan with our patients and move forward. That's exactly what we thought we should do. So we picked a rising risk group of people within our panel of patients, and we sat down with several of them. And one lady, she said to us, "I'm 91 years old. I don't care what your care plan says, this is what's important to me." And it ended up being more about end of life and eventually goals of care and all sort of that sort of stuff. So it was really important for the team to have the time and space to talk about how are they going to take this personalized approach and make it meaningful in their practice. Because lots of times we can read all sorts of evidence-based guidelines or recommendations, but it often requires a lot of translation to make it work in the world that you're working in.
Okay. So first of all, I'd like to say thank you for that talk. Being a primary care physician, I feel like you were preaching to the choir. I agree that's something that we sort of, some of it were like that, yeah, that's common sense, but it is nice to have it articulated like that. We used to give talks, and one of our slides was sort of this target shooting talk, and we'd kind of make fun of how many targets could we hit. And I'm sorry, Mrs. K, I know you can't stand up, but we've got to get your blood pressure lower. And so that title fits in many ways, because what's realistic and what can we actually do? So I come at this from a point of education and knowledge translation. So I think health literacy is a real big issue. My husband's a junior high teacher, and occasionally he gets a health class, which apparently nobody wants to teach in junior high. And I beg him, let me come in, because there's a few things I would like to teach kids. So when they get older, they're not going to come and ask me, and then I'm going to have to bill the government for it. So, just starting there, I don't have evidence for that, but I think that would be a really good idea. The other thing, encouraging patients to ask questions. I think that's a great idea. The thing is then, you need to provide physicians with answers. And I think that's some of the issue. I know sometimes physicians get a bit anxious when patients are asking them lots of questions, and they say, I don't have the answers. And so from a point of view where we provide education to physicians, what I think is really important is that provision of decision-making tools. And I saw online, the UK has a number of them. But one of the things I would propose, and there's some interesting research around this, if you talk about qualitative information, so you say, if you take this drug, this will improve your cardiac outcome, or there may be some rare harms. So there's been some research. So say in the EU, they said a common event might be about 10%. If you ask patients what they think that means, they think it's about 65%. So no wonder when I prescribe something, they come back and they say, well, the pharmacy says this might happen. I'm not taking the drug. Right? Or rare. We say rare, it means 0.1% in our mind. In the patient's mind, it means about 10%. So providing physicians with actual numbers, sort of numerical information that they can then discuss with their patients, because I think that's a huge piece of developing that healthcare literacy. So there's lots of interesting, and so that's some of the things we try to do with our group. The other thing I really like is the discussion of cost. And providing, one of the things I think with a lot of clinicians is we don't know costs. We don't know costs of medicine, we don't know costs of interventions. And so some of the things our group has tried to do is develop pricing documents, and we've done some guidelines, and in the guidelines we've listed cost. And I think not just taking cost into consideration when you make the guideline, but reporting the cost right there. So that allows the clinician to discuss with the patient and say, here's the medications, here's what it's going to cost you, some different things you can talk about. So some specifics that kind of improve that health literacy, I think, is really important. So that's kind of the main ones. Yeah, just that idea of really important to improve information transfer to physicians and clinicians and healthcare providers, and then they can have specific discussions. The other thing is like online risk calculators, right? So we talk about, your cardiovascular risk. Here's your cardiovascular risk. You're at 20% risk in the next 5 years. If I give you this Mediterranean diet, you can reduce that by 30%. And then I can show you exactly the benefit. And some patients will say, that's awesome. And others will say, not worth it. And that's their decision. But that allows them. And I think that's where we get that, where many clinicians wouldn't take that medication because they're already aware. There's a benefit, but it's not worth it to them.
Thank you.
Well, thanks, John, for inviting me. Your talk, Catherine, was amazing around health literacy, and that's what resonates the most with me. And we're so close in Alberta to having all of the ingredients to a really amazing health system. What, Braden, you mentioned about a bit of a branding issue, I think that's true. Strategic clinical networks have been an amazing partner in the work that I'm doing and that I've spent some time with before I retired. But that title doesn't really speak to the public. Like how does the public see themselves in that? There needs to be a way, I think, to mobilize all of us. And we need the graphic designers, we need the artists. I saw how you pulled in the poets. Those are the ways that both the professionals and the public's hearts and minds are captured. And that's how we learn. We learn through stories. You used a lot of stories in your presentation, and I would encourage all of you, I love how you brought stories out, because that's how we learn. As you were talking, my dad texted me twice. He's 82. He had a CT scan on Friday last week and has been waiting for the results, and he just got the results. So I'm thinking to myself, oh crap. And yeah, we have another appointment with the oncologist coming up. Those are the moments that, being at those next appointments with my dad, for me, having a chance for the noise to be dialed down is what's going to matter the most to me as we walk through those next appointments. The clutter on the walls, the mixed messages, the quality improvement posters are kind of inspiring, but they mean nothing to me when I don't know where to go to find out the information about the amount of risk that my dad is going to be facing. The transparency in the maps is fabulous. Yes, the government cares, but I don't think the public cares that we don't yet know the answers to what those maps mean. It helps us all to create and build the questions together about what our health system, with very scarce dollars, is going to focus on. We can help prioritize what those questions will be if you ask us. We care about waste. Yes, I want to know all the tests will be done for my dad. However, if you ask me about waste, I'll probably talk about the nurse, as my husband was being discharged a few weeks ago from having had surgery, where we were just said, take all the supplies you want. Well, really? I kind of grew up, and I hope most people have a sense of, if you take care of the pennies, the dollars will take care of themselves. And we see those little bits of potential for where waste can be addressed. Anyway, it was an amazing talk, and thank you so much.
I'll just say a couple of words before we... You can hear me okay? Just a few words before we get into the panel. I also want to thank Catherine and Braden, where'd you go, for great presentations. I really did enjoy them. I am a regulator at the moment, but I have come from a completely different environment from the military, where I have had a salary for practice for my entire career, and variation does occur. There's no question variation occurs, and so we have to ask ourselves, where does that variation come from? Part of it may be fee-for-service, but a lot of it may not be as well. So it comes down to behaviors. Some of the behaviors are driven by the stories, like you just said. Stories are very important. People hear stories, good and bad, which drives a lot of behavior. We talk about data and evidence, and some of that will drive behavior. But what we also know is that a lot of our primary care physicians in Alberta get a report every year with data in it about practice, but many don't know what to do with that data. How do we take the data, turn that into knowledge, which changes the behavior, which improves outcomes? You know, it's very important about how do we help coach people along and help them with that as well. Trying to use the physician learning program is an incredibly valuable resource, but unfortunately I think the people who already know they need to learn are accessing that program, and we're not actually reaching out to those who need the help. We know that practicing medicine, no matter what, or practicing in the healthcare environment, no matter what your profession is very hard to do in 2018. We've seen the numbers about burnout, and all healthcare providers and people working in the system are tired, and it's hard to do it. So how are we helping people? You know, as a regulator, I don't want to be seen as the person who's just simply going out there to find people who are doing things wrong, like emailing their patients, which is great. We want to find ways to provide better care and make life a little bit easier so we can get better outcomes for our patients. So we know that there's physicians that are out there struggling, and we want to find ways to be able to help them provide better health care, not use the stick as often as we can. That's, you know, it should be a very, very rare circumstance where we have to use discipline to change a behavior. But fundamentally, I think this comes down to behavioral change, and none of that is easy to do. And because we have such a diverse group of people that practice medicine in all our professions, there is no one easy solution. Unfortunately, I wish there was, but there just isn't. So I'm going to lead into a question, and Catherine, I hope that you and Braden would also be willing to answer some questions as well as we go through here, because it's great having the expertise in the room. So I won't specifically pick on you, but I hope if something comes up with a question, we can certainly direct it in your direction as well. One of the things that the reality is we have a changing healthcare system. Right? The world is going to change in healthcare in the very near term. One of them, as we've heard, we have a crisis for the cost of healthcare. We can't continue to grow like we have been. We know that there's demands from patients that are changing. There's expectations of the healthcare system that are changing as well. And on top of that, we've got this digital revolution as well, where there's all kinds of expectations about how you can get care in a digital world as well. So I'm just wondering, and I'll throw it out to the general panel to get your thoughts on that, the things that we've learned here today, what are some of the things we can pull out of that to help guide the care providers and the patients through this incredibly challenging time that we're facing over the next couple of years? And who would like to jump in before I point to somebody? Catherine's leaning forward. She goes first.
Okay, I'll go first. Well, I think we pretty much live it every day in our office. So every opportunity that we have as people are phoning in, we're educating, we're helping them advocate on behalf of themselves, asking the questions. I think your question, they are going through a complex system. We have a wall in my office. When I started, I said, what are the themes? What are the issues? And my manager down here, Catherine, is laughing because it literally is filled. And, there's an entire sheet around information and exchange of information sharing. How do we help people understand what that means? How do they, mental health, big gaps, can get into the system. But we probably have more demand than capacity, so how do we help people navigate through that? And so I'm going to go back again to some of the parts that we haven't done well, which is actually, and I've talked to my ADM colleagues, what are the communication? What do we mean by community-based healthcare? How do we get the message out about what we're doing differently with PCNs and the governance around that? What are the Charter of Rights in terms of, while they're very aspirational, actually we're doing bits and pieces of that right now. So it's partly trying to do that communication communication. And I think someone used the word branding. We have not talked about it in a way that others can understand.
I think it has to be, a lot has to do with transparency, because we do not share information well with providers. In Alberta, and I'll be controversial here, but we can do a lot better job of sharing outcomes with providers. We have to be, we are pushed back. I've been sharing with our orthopedic surgeons how they do with their total knees and their total hips and their cost per case. But boy, that was a very tough road to go. And the pushback we get from different groups, and not just the surgeons, but administrators as well. Believe me, in this province, you don't want to make one hospital look worse than another hospital. There's pushback in being fully transparent, and I think we have a long ways to go there. And I think that the SCNs have been an asset in this because they're across the province, but there is some challenges with transparency.
Thank you.
One other
Shawn.
one other comment I'd make is, I think one of the things we are very guilty of in healthcare is coming up with a solution before we understand the problem. And Connect Care, which I'm heavily involved with, we have a very clear idea of how that's going to solve a lot of problems, but we don't fully understand the problems, and it's not going to solve the problem unless we fully understand it. So as we start to evolve with digital technologies, with shared decision-making tools, those are great steps to move us forward and give us extra tools in our toolbox. But we have to understand the problem we're trying to address, and this issue of cost transparency has come up a number of times, which I think may have a value, but we have to understand what the underlying problem is first before we put in cost as transparency of cost as a solution.
So I want to actually ask Catherine a quick question here before we open it up. The point about sharing information and transparency, I think, is incredibly important here. And there's often a resistance to sharing information, or there may be some blockages to sharing information. It could be privacy laws that could be in place. It could be electronic health record systems that don't communicate information. And there's a significant duplication of work that occurs as a result of that. Is there a way that that's being addressed in Scotland as also a way of trying to reduce duplication of efforts just because we haven't shared information appropriately?
I don't think we do it very well either. And actually it's interesting when you ask the public, they think that we all share their information. So they go to the pharmacist and they think, why am I having to tell you again? I've just told the doctor 5 minutes ago, 5 yards away. Why? So it's bizarre that there is this worry, concern about sharing, when actually the public assume we're all doing it anyway and find it a bit inconvenient that we're not. We do have joined up primary care data in Scotland so that because they're all separate providers, there was no unified system, and we've made that so secondary care can then get an emergency care summary from that, and you can move between GP practices without having to repeat everything again. What we are then doing is something very interesting. The timing is similar to Your Care Connect, where we currently have our 14 health boards with the different tartan that I showed you, and they're all got their own electronic system, and we're about to procure for NHS Scotland one system, so that we will then have something that speaks in secondary care, but then will also speak to primary care, and the plan is that we would also then have optometry services, pharmacy services joined into that. I think that a whole lot of the concern needs to be addressed. Your point, don't solve it before you get to you realise what the problem is, and so we need to be very transparent with the public that is what that's going to look like. We have an opt-out of your data being used and shared. That's a signed thing when you register with a GP, and almost nobody says we're not interested, because actually the recognition is if we give you our data, that's for our benefit. It's not the government tracking you. So I think there's a lot of sensitivity around data, but actually it's our messaging around the utility of sharing that, utility of using it also to provide services. So some of our primary care data can be pulled anonymously from all of our practices across Scotland, and we therefore know how many people there are with type 2 diabetes, we know how many people there are with dementia. You can actually use that year on year to plan your services. So it's massively beneficial, and I think we need to get away from that sort of big brother's watching me thing. But again, that's because we haven't been transparent. It's partly our doing.
Great. Thank you. I wouldn't mind getting the patient perspective on this as well. So, Troy, I wouldn't mind getting your thoughts on just the access and availability and the sharing of data in healthcare. You know, like I said, we have a lot of privacy laws that are in place that are there to protect information, but I'd be interested to know, and Kathleen, it'd probably be good to get your thoughts on that as well, especially with your time in government as well. You may have a very specific insight on it. So, Troy, what are your thoughts?
Well, I can't wait for the personal health portal to come. I mean, I know that part of the delay was around having it mobile friendly, which is great. I pretty much do live on my electronic device, but for people who live in poverty, you know, between my family members, I have quite a large extended family members. We counted one day, we have 30 electronic devices we can go to. Well, that's not how most of the world works. You need money to have a data plan, and if you're living at, you know, a homeless shelter and you need to go somewhere to get information, you get it from a trusted person. So it will continue to be important to have access to our electronic information, but like anything, it's a tool, and we still need all of the professionals who care for us to respect our voice when we're asking questions and to have time to listen. So I think there'll be a bit of a, you know, learning curve for everyone, but it's got to be here. Yeah.
So we're really, you know, obviously very excited about having a portal and having access to information, and the kinds of things that we're seeing in our office particularly would be around clients that have adult children. So and particularly mental health. So mental health is our big area of concern right now, where we have then questions around, can I access this adult individual's records because I need to help them, I'm the guardian to help them, and it's very complex, or dementia. So it goes various areas of restriction. Looking at the policies, and so I'm really encouraged, in having just left and working around what are the policies to ensure that it's safeguarded, but at the same time that we're not putting blockages in place that we can't help individuals and have to recreate things over and over again. A big issue for many are the multiple ministries that they actually have to navigate through, particularly for the children and children's services. So getting information between those areas is I guess, another one. So we try to guide people through making sure they have the right safeguards, but there are those pieces where there's a lot of policy gaps where we have individuals that are needing to help they're the caregiver, and they're needing to assist and help, and we need to figure out safeguards on how to do that.
Great, thank you. I think we should open it up and get some questions from the audience. So if people want to either, John, how do you want to work it? Are you going to run the microphone?
I can run on this side if people wave, because I need to address my obesity. And the other side, that people can kind of stand to the mic.
So while people are thinking about it and about to put their hands up and wave,
And I have a question.
sorry.
Go ahead.
What we'll do is I actually want to ask Sheri a question, because I was at a meeting the other day with Braden and Dawn, and we were talking about appropriateness. And one of the things that I hear as a regulator often is people order a lot of tests because they're afraid of litigation or afraid of missing something. There's a fear that also drives some of the behavior. And I'm just curious, as a nurse practitioner, and do you and your colleagues also share some of the same, or do you see that in the same practice as we do as physicians? That sometimes we are ordering certain tests or procedures because there's a fear that is driving some of that behavior.
I don't think it's necessarily unique to the discipline. So, I suspect nurse practitioners who work in other specialty areas may or may not have similar situations. In primary care, I don't think it tends to be as pronounced as other specialty areas in that, hopefully we know our patients, we know them well, and we know them for a long time, and it's more about the relationship that we develop with those patients so that if it's appropriate, we can have an open and honest conversation about what they do or don't want to do. And I don't think that that's unique to any discipline, so, in primary care anyways.
So, Tina, what are your thoughts as a family doc?
Yeah, so I agree. A lot of what you said I think is really true. And again, yeah, we do have some physicians who do express concern. If I don't test this and I've missed it, then there's potential I'm going to run into trouble. So there is that sort of fine balance for sure. And again, when we sort of look at the evidence around many of these interventions, they're not that productive. If you want to talk about overuse of lab tests, the one thing that I've seen actually just this morning, so patients who are seeing sort of multiple providers, and then I just looked someone up on Netcare, and she'd had her calcium and magnesium done about 8 different times and it's because we're busy, we don't have time to check Netcare every time, and so unfortunately, without that continuity of care and that strong sort of primary care piece, you see this repetition of unnecessary labs, which I would be so curious to see how much that's contributing to sort of this overuse of labs. Yeah, whereas the continuity, that's such an important piece of recognizing, or saying to the patient, we talked about this last year, nothing's really changed, I don't know if that needs to be done again, and we have that ability to sort of discuss that part.
Thank you. So do we have a question from the audience?
Okay, I feel like I'm slightly abusing host privilege, but seeing as nobody else. I was very interested in the suggestion from one speaker, I'm not sure who, that maybe the cost of things should be visible to the clinician. As an economist, on a good day, I think I know what cost means. Most of the time I know that I probably don't, and it's very complex. What training would clinicians need to have, do you think, in order to have those sorts of conversations with individual patients about the costs of their care? I might also suggest that you ask Braden to comment on that as well, but it's to the panel plus Braden.
I'll make a quick comment. I did mention something to that effect, and I'm not an economist. My idea of cost is very simple. And it starts off with when I would prescribe patients medications and they were scared to tell me for 3 months they hadn't filled it because they couldn't afford it. And I had no idea. That was $300 a month. What? So basic things like, medications, I think, we tried to sort of figure out cost of investigations, but as you've alluded to, that's a very, very difficult road to go down, and we never really did get a good answer. But that would be something else that would be really, even an x-ray, how much am I, again, an estimate would be fine. How much am I costing the system when I'm doing these, if I think it's unnecessary? So I think, because from primary care, I would say we're overwhelmed with everything simple. I just need some simple basics that I can discuss with my patients. And I'm sure you're thinking much more complex, but I'll let someone else know.
But I would just add to that is I really talk about it in this, I do use it a lot. I talk about it, what's the cost to the patient, both financially and to themselves. So, do you have time for this? Can you get there? Those sorts of things. But financial implications are a big one, because in primary care, 9 times out of 10 patients often have to pay out of pocket for it.
But I don't think it's a simple, transparent thing to produce. So the example, I've had discussions about this quite regularly. The best example, I think, is a blood thinner called Coumadin, which is very cheap, about $1 a day, versus the newer agents that are about $200 a month. The newer agents don't require any testing to check whether they're in the right range, so the patients don't have to go to the lab, they don't have to pay for parking, they don't have to follow up with their family doctors afterwards. And the economic studies by the health economists, who are much smarter than me, would show that for the system it's actually cheaper because they have less complications, less admission to hospitals, and a better quality of life. But if you prevent that on an order set of $30 a day, at $30 a month versus $210 a month, you would be swayed to using the older agents versus the newer. So it's hard to present that three-dimensional data in a one-dimensional format like an order set. Or so I don't say it doesn't mean we can't do it or we shouldn't do it. I think it just needs to be tested rigorously if we're going to actually do that and figure out the best way to deliver that information to clinicians and to patients.
Braden.
It's great to have this mix of people on the panel here, and it's great to listen to the discussion. And as Tina talks, I think studies that have shown the costs, I think actually the next step is, because you won't necessarily know what the cost of the alternative is, the cost, and then a helpful suggestion, that actually covers SIL was the most expensive ACE inhibitor, consider this, to make it easier for the doctor. Otherwise we get fatigued with all the prompts, and it's actually interesting, these behavioral sciences around how you help people make decisions. I guess the other thing to say is it's interesting, Shawn talked about actually what's the cause, what's the actual cause of the problem, or what's the barrier. As I recently, we did a little poll of the kidney doctors, and no one likes it when a person arrives without their lab tests done, because we feel like it's a visit that wasn't helpful. But everybody's standard labs is so different, and I started looking, my secretary, because I worked with 2 other doctors at the time, I did the same labs as everybody else, even though I didn't look at some of them. So I recently completely pared it down, and now I'm thinking, well, I need to be a bit smarter. I need to have my secretary actually look on the system to see if they've had lab tests in the past couple months. That's fine, I don't need another one. And so it's actually not that I don't know I shouldn't be ordering this stuff, it's that that's how I set up the system in my office, and I need to change how I set up the system. It's not difficult, but that simply showing me the cost of the test wouldn't be the issue, because my secretary is actually ticking the boxes. I just need to change the process in my office.
This is Scott. When I fed back the information to my surgeons, what they were spending on a hip replacement, it didn't seem to have as much of an effect. I was telling them, you're spending $8,000 and you're spending $15,000. Same patient. It didn't seem to have an effect. But when I showed that information to the surgeons as a group, and I showed the variation in costs, I showed who's using 1 unit of blood and who's what's the percentage of transfusion you get with your different surgical procedures. Showing providers that information, whether it's costs or whatever, I think does change behavior. I think just the cost itself doesn't seem to affect them, but how they relate and how they, showing them actually the spectrum and where they fall. When you realize you're in the 5th percentile and everybody else is better than you, they've moved. So that's a real life example for that. And I just think you have to be careful how you share that information, but there is a way to share costs to move behavior.
Great, thank you. I think we had a question here.
So I'll start my question with a bit of a story. Pardon me. Last month, my family was handed a autopsy report, and we were there wasn't a lot of guidance that was given with that. So, being the only person with a science degree, I was given the task of, okay, what got him? And what we have to turn to in a lot of cases with patients is online resources like WebMD. So how can this be used as a strength or a feature rather than the way that some of my newly trained physician friends are saying, oh, it's the worst when they come in and they've already got a diagnosis from WebMD for talking about realistic medicine and engaging patients?
Thank you. Anybody want to jump on that one? The value of the future of WebMD or Dr. Google.
I'll just say one thing that an example, so I looked at, so the UK, the decision aids that you have on a website, I looked at that and I thought, isn't that neat if we had a resource like that and I think as we develop with technology, we will, and there's lots that are being developed, it's just the question is information overload, right? Where do you go to actually get the most accurate? And yeah, so I guess as we move forward, will we see more sort of resources that are evidence-based that are directed specifically to patients or that you could direct patients to? Like when I have people come in and, you know, they're worried they have trichotillomania or whatever, that's happened this morning. I can look up a resource and say, here's what it is. This is, you know, the evidence around it. And if I had that easily accessible, and there are some, you know, those types of resources, I think, again, it improves that communication in a really simple, straightforward layout. But you're right, like we have a bit of a ways to go in improving the information, how we communicate that to patients.
Right.
And in the work I'm doing with Healthcare 101, it's a citizen co-led project to help Albertans understand how the healthcare system works. We're using My Health Alberta. And that was chosen because I think it's our best resource in the province. It's not sexy. It's got the information. So again, I think that for the public, when we're in crisis, when we're looking for information, we do need to find resources that are relevant to Albertans. So how do we strengthen that?
Shawn, I'm sure nobody comes into the Emerge with a pre-diagnosis, but I'm curious what your thoughts are on that.
You know, it's actually, we did a little project recently that's been scaled up across the province around giving patients information about CT scans for head injury before they saw the physicians, because a common idea is that they come in wanting a CAT scan, and they want a CAT scan after head injury because they want to see if they had a concussion. And we actually, through this infographic that we had, and someone else mentioned a graphic designer, we had a professional info designer help create this, had patients involved, got their feedback. And the expectation was, you know, 2/3 of patients thought they always needed a CT scan. And then we gave them information saying, actually, CAT scans are only to diagnose bleeds that need neurosurgery. And they said, well, I drove here for my soccer game. I don't need neurosurgery. And then we talked about the downsides of CAT scans in terms of radiation and length of stay in the department. And not surprisingly, the number of people who expected a CT scan for all head injuries decreased dramatically. And this has been shown in other Choosing Wisely initiatives, that's providing that information to the patient before the interaction, and in a way that's meaningful to them and they can understand, can actually change their behavior. And you could have synergism of what the physician thinks is the best recommendation and what the patient's expecting. And then you get much more agreement than them coming in saying, I want a CAT scan, you saying, I don't want one, and then you compromise in the middle rather than kind of have a shared vision of what you need. So I think one of the things, I don't know what the right answer is, but I think one of the things we don't need to do is create more of these, because there's so many different resources out there. It's a matter of curating them and getting them into the hands of patients and making sure they're designed with patients in mind and with patients. Because when we first did our project, we were amazed at the numbers that we used, 0.01% neurosurgical lesions, and said that doesn't resonate to me. 1 in 1,700, I know what that means, but 0.01% doesn't really mean anything. So it was really powerful to get patients' perspective on that, and words like amnesia didn't mean anything, not surprisingly, but confusion was something they understood. So I think curating them, making it designed with the patient, not for the patient, is key.
Sheri, what are your thoughts?
We have lots of people who use WebMD, and I always try to start with where the patient's at. So if that's what their place of truth is, then let's go from there and try to figure out what will work and what won't, or what's really going to be harmful, and work together forward. But I don't think it's ever going to go away. Patients will always likely navigate to something that feels right or attracts them, and yeah, especially the younger generation. That's where that's going to be the first place they go, the first place. So.
Yeah, so I actually think that the future is going to be much more of that and not a lot less. Patients are looking for information, and if they find that they get it easier, quicker, and it's more appropriate for them by going to WebMD, well, then we need to think about how we're communicating that. So, Shawn, I think that's a great, your approach there of trying to communicate it in a way that's well understood means people will come to the healthcare system and not to Dr. Google or WebMD. So we need to learn from that and get better as a system to be able to provide the information in a better way. But we'll also see the evolution of artificial intelligence that is on the very near horizon and may actually be better diagnosticians than a lot of clinicians as well. Another question.
Hi, another health economist. I'm Jeff Rand from the IHE, and my boss very kindly set me up for this. He hasn't told me to say it, but he's started the question path. And I want to thank Dr. Dick, actually, for inadvertently getting to where I'm going with this, which is, you talked a lot about costs, but we haven't actually spoken about value. And this is a question about putting costs in front of doctors and patients. Can they decipher if that cost represents good value? And can you do that in a consultation with a patient, putting a cost up and say, is that good value? You gave the example of the $30 versus $200 per month drug. Is that good value to who? To the patient or to the health system? And is it fair to put that burden on the patient of making the choice for the health system to say to them, you pay $200 a month so that somebody else can access the health system, or you pay $30 a month, which is much cheaper for you. So it's a sort of nebulous set of questions, but getting around cost versus value and how we approach that.
So basically, are doctors smart enough to figure it out? No, I'm just kidding. That's a great question. Who wants to jump on that?
I think there's two parts to this. So one of the conversations that we would have, because we would get the people that at the end are phoning in and saying, I want the doctor fired. I tried everything, and I don't think that they're listening. And so we walk through a series of questions that say, to really ask them where they're at and what the problem is, and is it really that, or do they have the tools to go back and ask the right questions? And some of it is a little bit about your 90-year-old that says, I don't want to go to a pre-admission clinic 4 times to do something that I know isn't really going to work for me anymore. Are there some other alternatives? Are there other questions that you can ask? And the value in that, sometimes we are able to share some basic costs with them to say, yes, you can go for this type of care. It's going to cost $5,000. Have you talked to the doctor about these other options? So we do a little bit of that, and we do try to bring the value in. I think the other value or the other part of the equation is exactly what you've said about, yes, I prescribed something and I didn't really know that they couldn't afford to buy the prescription or fill a prescription, and therefore they've now gone for another whole month without that medication. So it's a two-way street of communications around the value, and I suspect from what we're hearing is there's not a lot of I'm going to say providers, and I'm putting that in the big general providers, because not even just physicians. We have lots of multidisciplinary teams that have had an opportunity to have that conversation. So I think, again, we're starting at a place now where we're trying to have the conversations, have that dialogue, and today I think is a really, really good opportunity, and thank you again for bringing this to our forefront, because our office is really a partnership. It's to coordinate between all of our players, and we bring forward what we hear as kind of the real hardcore issues and problems, but we're not here to point out that there's a problem with the system. That would be the worst thing in the world. It's really, really to try and work together to figure out how we get to the next stage.
So I think patients do understand value. I don't think they always understand costs, and how we present that information has to be a bit, there has to be a bit of a unique way to presenting costs, but they do understand value. And I think if we do a good job of presenting what we do and why we're doing it, I think patients understand. And I would, if my patient, do you agree?
I think what we don't understand are healthcare costs. We understand our own costs that we're incurring, which often healthcare providers do not understand. So it's not just the cost of the medication, it's the cost of childcare, it's the cost of elder care, transportation, getting to and from appointments, if you can even get a bus to go where the clinic is. It's all the special diet, the special supplies, knowing that there's even, supports for supplies. It's all of the costs, and that's the hidden piece that when there's not that open conversation about the implications of a particular treatment or a diagnosis, that's when we all end up tripping on each other with sort of mixed expectations, I guess, about the combined value. So it is complex.
So I'd actually like to get Catherine's thoughts on this, because that was a big part of what I got out of your presentation, is what is the value to the patient, and the difference between what does something cost and what is the value to the individual, and whether either patients or care providers themselves are very good at assessing value. And do we have the conversation of what's valuable to the patient versus what perhaps the care provider assumes to be valuable?
And it's definitely complex, and I think the definition of value and cost, or cost in monetary value and value of an intervention to that person, and the burden, I think, is what Troy's talking about that may go with that. I for research purposes only, obviously, I have had 3 children in my own maternity unit, and that gives you a very interesting perspective on life and being a pregnant person in your own unit. I wouldn't necessarily say you need to have a hip replacement, but you might, But what I do encourage people to do is to walk the journey of the people that come to their department and sit in the waiting room. And the sitting in the waiting room, mostly actually at the time, my husband with me sat there saying, why are there 3 people here? One person would do. Why do you need someone to call you from the waiting room into the... He's a health economist. And so there is all sorts of stuff you see as the informed patient. And I think, I know I sound facetious about that, but I genuinely do. I think that people should experience at least the practicalities of what we ask people to do. And to be honest, if you need a hip replacement, those corridors are extremely long to walk down. So that's partly an understanding, and I'm very surprised at and I suppose I showed it with Molly, that Molly had been going home to that home all the time for years, and the only when she said, I don't want to come back into hospital, was the first time somebody went and looked at it. So we don't know people's circumstances, we can't ever be them or live them, but I think that's where that exploration of where, and it's not just value to them, it's their values. So I was struck once when I had 3 women who'd had a screening test result who were pregnant that was going to lead them to have the option of an amniocentesis, which of course carries with it risk for the baby. The first woman was straightforward. The second one, then she had a risk of 1 in 400 or something. And she thought that was completely unacceptable, and it wasn't. It was absolutely for her the wrong thing to do to ignore that. And the next woman came in, literally the next one, and her result was 1 in 10. And I, 1 in 10, wow. Ooh. And she said, but that means 90% chance, Dad, the doctor, that the baby's okay. And I went, yeah, 1 in 10. Yeah. And she said, that's fine. Stood up and walked out. So there's getting into that person's world, as well as because my choice of what my amniocentesis risk is something different from those people's. So the cost issue then, I think the risk of some of the cost is that we we, the same as you, have taxpayers. And if we are trying to say, well, you can't have that, they say, well, I've paid my taxes. I've worked since I was 16. What do you mean, doctor? I've never been ill before, and you're telling me I can't have that thing because it costs a tiny bit more. So there's a huge risk to that. The cost bit, though, from Troy's point of and Tina saying you didn't understand they weren't filling their prescriptions. So that bit is important. We have actually a system that flashes up in primary care, the cost, as you prescribe it electronically, the cost comes up. And if you go for something that's off the generic list, you can still do it, but it says, did you mean to do this one? This costs this much. And it doesn't stop the individual practitioner, that wouldn't be right, but that does, I understand, change behaviour, because people then think, oh crikey, I didn't realise that statin was 5 times more than that one, it's not likely to be 5 times more beneficial. So we do have that cost in general practice, but it's only for drugs. And the other piece then is that complexity that you talked about, Shawn, where is that I have my colleagues who say that the limitations are put on the medicines because it has a price tag. But what if you're a maxillofacial surgeon who decides to do some, their words not mine, some horrendoplasty on somebody who is going to spend 3 weeks in ICU and then die of sepsis? Nobody says, you can't, that's not a listed drug. You can't do that. Whereas we do put a cap on some of our medication. And that is where I think some of that understanding of the cost to the health system for something that actually almost everybody in the room knows is futile, as in fact does the patient. And I have a really nice slide which says 2 weeks in ICU will save you a very difficult 1-hour conversation.
Thank you very much. Do we have a question?
So actually my question is for Catherine, so you might as well keep the mic actually. So I came over here. First of all, I want to thank IHE for facilitating this discussion today. I found it very informative and fascinating on many different levels. My name is Beth Kidd. I'm Executive Director of the Health Coalition of Alberta. We're a patient advocacy coalition primarily made up of healthcare charities and organizations, but also individuals, and some of our members are here today. One of the concepts that we have talked to government about and our members, it actually came up from some of our members, and that is the need to move from a task-based model of care to one that is relationship-based. So obviously, your discussion around realistic medicine really resonated with me because it's aligned to some of the things that we have been talking about. So we heard, or what I heard from you today was most definitely around patient partnership, around the importance of listening to your patients and making choices that work for the patient and therefore driving, hopefully, savings to the system or improvements in the system anyways. Unfortunately, what I heard immediately following that from Alberta was cost effectiveness. And it was about physician choices driving cost effectiveness. It was not about listening to the patient. Now, I must admit, some of the people on the panel, for sure, I have heard that message more so from some of the people on the panel. But this kind of juxtaposition really highlighted for me what we've talked about at the Health Coalition, in that we're talking about a huge cultural shift that's going to have to take place to move towards a relationship-based model or realistic medicine. So I was wondering, Catherine, if you could speak a bit about your experiences or the experiences in Scotland, and did you have that health system cultural shift that had to happen to put the patient at the forefront of these decisions and ensure that healthcare providers have the time and have that conversation with patients? What would your recommendations be based on your experiences and how we could move that forward in Alberta?
I think that what has been said to me most often is that realistic medicine brings people back to why they went into healthcare in the first place. And I had I spoke at the University of St Andrews, and the student, third year student, she came up, she waited for everyone else to go away, and she queued up, and she obviously didn't want to ask her question in the big public forum, and she said, I really like that realistic medicine stuff, but I don't mean to be rude. Why did you need to write that? Because isn't that what everybody's doing already? And I didn't want to burst her bubble for a third year medical student, but for her it just sounded sort of obvious. And that's what people come back to me and say, that this is about being a professional. This is about what my own values were in coming into the profession, whatever that may be, nurse, doctor, and I want to provide care in this way. So that I suppose is the turning point, is people are on board. I think the system, and actually Milton Sussman said this morning, and this is him talking about your system, so this isn't I haven't the knowledge to say. He said, does our system force people to act differently? That is actually, some of that is not them as being bad or trying to bill more, or it's the way our system has forced people to practice. And I suppose that's where realistic medicine came from, because that in Scotland it's different without the fee bit, but it was people were telling me they were not able to practice medicine in the way they wanted to, and they wanted that relationship with their patient. What I would say is I struggle all the time. Every audience asks me about the time. We don't have time to do it. And as I've illustrated, I think some of that is reasonable, but some of that is not. They also say that they are going to be sued or taken in front of the GMC because they know that they haven't done a test, and what if we find something else? But again, and this sometimes then plays back to the time bit, actually I think patients are really realistic about that. I mean, I could test you for a million things and we still might not find the thing. So, but again, you don't always have time to have that conversation with the person when it's easier to do the order, and I understand that, and I also understand from some of my colleagues that it's easier to wait list somebody for a procedure than have a conversation that means that they might or might not come back, and what if they didn't understand, what if they didn't represent it. So I don't think that we are miles away from you at all. We have not cracked this in Scotland. What I seem to have done is to articulate something where people then are pushing back a bit and saying, I can practice like this because that chief medical officer says it's okay. But I don't think my doctors, my nurses, anyone are different to yours. This is partly the reason I think it's taken off, is people just go, yeah, obvious, like the third year medical student. But perhaps the system has driven them in a different direction, and I suppose that's maybe where your conversation with Milton comes in, that actually, well, that if it's the system, it's not the patients or the providers, somehow your changes to your system might have an impact.
Okay, and to be fair to Braden, he spoke about stewardship of resources specifically because he was asked to, in terms of, but I think there's a lot of, with the strategic clinical networks of doing learning and a lot of the principles of the kind of the realistic medicine area, but a large part, and we're the Institute of Health Economics, so we always have to talk about cost in the end. But I do think actually a lot of the realistic medicine is around the role of the citizens and how much can the healthcare system continue to ask of all sectors of society to pay for itself, and how much can it self-improve to fund its own ongoing innovation and change. But so Scott, I don't know if you want to kind of wrap up, and then we'd have closing comments from
Yep, if
Dr.
there's no
Frick.
other questions, then we will wrap it up. We do have a question. Oh. John, run.
Oh, sorry. I wasn't being attentive enough.
I really wanted to build on your comment and go back to Catherine's slide and stories on social determinants of health, and her stories that really resonate. Is it a medical solution, and how do we determine that? How much cost can we save? How much value can we add if we really enhance our primary healthcare system? So if we've got all Albertans with a regular primary care provider who's supported by a team, who know how to talk about what matters to me, who listen to their patients, who are enabled to do that, who are trained to do that, to really, truly understand what are the challenges, what are those social determinants of health that are getting in the way? Income being number one impact on their health. And so we're not swirling with the medical solutions, we're supported with all the sectors to fix the roof or get the railing installed. And so how are we supporting our primary care teams with, you know, the quick access to the specialist to say, not urgent, and or here's community supports that you can tap into. And I know, Sheri, you can build on that as well, and love to hear how that's integrated in Scotland as well.
Who would like to start with that one? Sheri, do you want to touch on it?
I think certainly in primary care in the last 10 years, building the teams into the practices has been a big job, and we're working really hard at it, and we're doing pretty good actually. Teams, as they work in different ways with patients and take the time to figure things out differently, social determinants are forefront now, right? Because we often realize that it isn't about the medication that we can or can't prescribe. It's about many other things, and it's often about connecting them to something local that will make a bigger difference than we can. But one thing we can build on is that hopefully they have a relationship with that team, and it might not be, it can be anyone that they connect with in their primary care clinic that they can reliably come back to. So when they're down and out and they don't know where to go, hopefully they will think of us, and we can help connect them to something that will work for them.
Tina?
Okay, I'll just add on that. So, it's really important. I have a colleague who works in Northern Alberta, and she, a few years ago, told me I had these 10 patients. They were terrible diabetics. Their A1C was 12 to 14, and she said within a year we got them all down to at least around 8. And she said, you know what the intervention was? They all got houses. So really speaking to that, like the importance of that. And so in our team, we have a social worker who is the most popular person in our team probably, because she helps, she is amazing. And it is amazing how many people will come to like you talked a little bit about that, Kathleen, they'll come to me seeking medical care, but it's not really medical care they need at all. They need help. And so I think the medical team, like that patient-centered medical home, is such an important concept. And then when they come back, then I know what medications they can fill and what they won't fill because of what have you, or all these other things you understand that, have a great impact, much bigger than anything that I can really do in a medical way often.
Kathleen?
I think I would be remiss if I didn't just share very, very quickly. I have had the opportunity, and I was mentioning our valuing mental health, and I had the opportunity last week to attend a session with the Canadian Mental Health Association Calgary peer educator support program. They were graduating some peers. And what was very fundamental to me was when we walked into the Recovery College, and there is one, and there is other groups across the province that are doing this, what was very fundamental is they were very much part of the health system, and I would be remiss in not mentioning a very big piece of our partners outside of here. And I was really reminded, I guess, when the coalition spoke about this, about things, because what was important is that it's not a group of peers that are doing assessments and treatments and telling people what to do and how to do it, but they have been hired, they've been trained, they are lived, experienced people that have gone through the system themselves, and they're there to help other people. So they're actually an extension of some of our work. And I feel that when we're talking social determinants and we're talking about a number of factors that interplay in people's lives, that there are other groups that we have need to, I guess, embrace as part of this journey, because they will actually have a very big role to play in this.
I would say I think this is one of the many areas that the SCNs have done really well in terms of care pathway development, connecting different silos, getting people focused on some of the determinants of health from not just from a treating disease perspective, but preventing disease, and challenging some of these big issues that individual providers and individual clinics couldn't challenge on their own. But when you have a SCN that's designed for cardiovascular health, you're much more able to identify those issues and have a province-wide approach rather than a bunch of individual projects at different sites. So I think that's SCNs have done that very well.
No, I think, Catherine, one of the points to the question was asking what some of the challenges Scotland's had in this area. You told the story about, the lady who wanted to go back to the home, and there was actually money put into modifying her home to allow that to happen. And I think that for many of us, that would seem like a real stretch to be able to come into the healthcare system and then get your roof repaired. But it really probably saved the healthcare system a considerable amount of money by not being in the hospital allowing to do that. I just wanted to know what your thoughts were on that.
And that's our health and continuing care integration piece, which, as I say, was only 2016, and everybody keeps saying, "How's it going? Have you got measurable outcomes?" And I say, please give us, less than 2 years. This is culture change. These are people who didn't know each other, where each other's offices were, suddenly working together. So I genuinely think that this is a seismic change, and we will not have measurable outcomes. We have on that sort of story basis, which that probably wouldn't have happened. She would not have gone back because there wouldn't have been an ability for somebody's budget to fix the house. She would have gone somewhere, exactly as you say, paid more money, she'd been less happy, and actually the facilities are full. So she might have waited in an acute bed, the story. The other part I hear about the health and social care integration is just back to my walking in your own patient's shoes piece, which is that people are the nurses on the ward, when we have people, that's awful term, bed blockers, I don't know whether that's what you call people when they're in an acute bed and they're waiting for a place in a continuing care situation. And what's happened is the nurses on the wards are now speaking to the people who are actually finding the places, and they know each other, and the people come in and they say, "Oh, she likes, that's where she lived, there's a home here and there's one over here, I think she would like this one." There was just a piece of paper before. We sent it from the acute system into I don't know where, because I'm an acute system person, it just went into a thing. And so almost the personal relationship thing is those silos that we all are in. And in fact, I heard that described actually really, really clever. We've got silos, but they've got glass walls. We can see the person, but we're really not interested in interacting with them. I know they're there, but I like my glass wall. So that will come, I think, but I can't tell you, I'm afraid, that it's a sweeping success with lots of money saved or money spent in the right places. But I suppose when I say it out loud, it's sort of obvious, because the person is the one going through that system. It's my mother or whoever's going, she's the one that lives it. She's not the piece of paper that says this woman needs a continuing care bed. So the fact that the system recognises that person is the right thing. The primary care point, we are really moving to having those all sorts of practitioners, encouraging clusters of GP practices. I think you are starting that here. We have the GPs then can employ their own staff, so we would have nurse practitioner, they would do lots more screening and cervical smears and vaccines and a lot of very good work. We would then be having a physio and nutritionist in that practice, and those practices joined together can then afford much more care. And we're starting to set them up in community hubs. So there's a hairdresser, and there's a creche, and there's a gym class, and then you can also have some of those people helping with the benefits in an office as part of a big complex that the community starts to see as its own. And we've certainly had big success in our areas where people don't access care by bringing people in because they're going to get their hair cut or they're going shopping. And that actually, we think probably that it widens access almost as an unintended consequence because people see it as their own in their own, and they do clever things like offering blood pressure screens and things as you're walking past. So I think that strengthening is, I think, your point here of that primary care and that whole wraparound that Tina has talked about that the primary care provider can give is absolutely the way forward.
Well, thank you very much, and thanks for contributing to the panel discussion. It was great to have the expertise of both yourself and Braden. It was you thought you were off the hook when you finished your talk, but it's great to have the expertise in the room. But I specifically want to thank everybody on the panel for taking the time out of their day, and so please everybody join me in thanking them.